So maybe let's just kind of walk through your cystectomy versus TMT talk. Patient counseling, first things first, management of the bladder. And of course, we'll talk about diversion and those aspects. But, just 101, how does this kind of go? Do you all have a multidisciplinary bladder clinic?
We don't have a clinic, a multi-D clinic for bladder cancer. We do, however, have a very close-knit group, and we have very, very busy clinic. So I think it really comes down to the urologist to describe all this to the patient, and sort of just like we discussed neoadjuvant chemotherapy. I think we're sort of the first stop in making these big decisions of where the patient's going to go. Look, I think I've matured through the years, and what we used to think, many years ago, as surgery was better than chemoradiation. You see the data over and over again, whether it's from Toronto, from Mass General, or from Europe, specifically England, that TMT is effective. However, there are a lot of sort of limitations and or selection biases in these studies that have to be acknowledged. I think it works best in a patient with muscle invasive disease T2 to T3 N0 at most unilateral hydro, and the patient being able to tolerate and come back for the maximal resection and the radiation and the chemotherapy. There's a lot involved, and I think there's so many limitations. CIS is the other one. If you have extensive CIS, they're not an ideal candidate. We have SWOG 1806 open here. And I try very hard to accrue for our radiation oncologist for that trial. And I was just writing her an email. I said, look, out of the last 10 TURs that I did, I tried to line up for you, only 2 were candidates because of these various limitations. The tumor has to be small. We have tumors that are greater than 7 centimeters. So I think 1806 is a very well thought out trial. This is the chemo radiation plus minus atezolizumab for definitive therapy of muscle invasive bladder cancer. And the inclusion criteria for that trial is a great place to sort of think about where it's appropriate to do TMT. So if the patient is a candidate, I certainly will offer it. I will mention it. I will tell them that the cystectomy rates in modern TMT series is 15%, not the 25-30 that we used to quote in the past. And that if they have recurrence, most likely they're going to get a salvage cystectomy. If it's early, they're probably going to be fine. But the chance of getting a neobladder perhaps is somewhat compromised. Although we have done neobladders post-radiation, it seems to be okay in very, very select patients as well.